Welcome. In this clinical review, we're going to break down hepatitis C, focusing on the high-yield information you need for your clinical practice and, of course, for specialty exams. All the information we'll be covering is credited to the work of Dr. Mohammed Naji Mohammed. Let's get right into it.
So, here's our game plan. We'll start with the big picture, the public health side of things. Then we'll zoom in on the virology and how it's transmitted. After that, we'll cover acute infection and diagnosis, and we'll wrap up by looking at prognosis and the progression to chronic disease. All right, first up, public health. It's really important to get a handle on the scale of the problem to understand why hepatitis C is such a major concern, especially right here in the UK.
Let's anchor this with a number, 200,000. You know, that's the estimated number of people in the UK living with chronic hepatitis C. And that's not just a number on a slide. It's a huge reservoir of infection. It represents a massive patient population that we need to identify and manage before they develop serious liver disease. So, who are these patients? Well, there are two key groups that should immediately set off alarm bells in your clinical mind. First, anyone with a history of intravenous drug use. And second, this really important historical group, patients who got a blood transfusion or blood products before 1991. That's when effective screening came in. So asking about these two things is absolutely fundamental. Okay, let's shift gears and look at the virus itself. Understanding the bug is key to understanding the disease and how it gets around.
So, what are we dealing with? Hepatitis C is an RNA flavivirus. Now, the RNA virus part is the really crucial bit. It means it's sloppy when it replicates. It mutates a lot. This is exactly why it's so good at dodging our immune system and why, as we'll see, developing a vaccine has been so incredibly difficult. And clinically, remember that incubation period? About 6 to 9 weeks. Now let's talk risk. How does this actually spread? Well, if you get a needle stick from a positive source, the risk is around 2%. What's interesting is that vertical transmission from mother to child is actually higher, sitting at about 6%. And sexual transmission, well, it's less common, under 5%, but it's definitely a recognized route.
And speaking of vertical transmission, here's a critical point. You have to know the mother's HIV status. If she is co-infected with HIV, that risk of passing hepatitis C to her baby goes up significantly. It's a major risk multiplier we have to consider in antenatal care. This brings us to a really common clinical question, one you're bound to get. A new mom tests positive for hepatitis C. She wants to know, is it safe for me to breastfeed my baby? And the answer is a clear, confident no. Based on the evidence we have, the virus is not transmitted through breast milk, so breastfeeding is not contraindicated. That's a hugely important piece of information you can use to reassure new mothers. And this just hammers home the point about it being an RNA virus. There is no vaccine for hepatitis C. This is a central fact of our entire strategy. It means prevention isn't about a jab, it's all about harm reduction, targeted screening of those at-risk groups, and, crucially, treating active infections to reduce that reservoir we talked about. Okay, so we know the virus and how it spreads. Let's move on to the clinical side. What happens when someone is first exposed, and how do we actually lock down a diagnosis? Right, and here is the single biggest challenge with hepatitis C. Look at that. A massive 70% of people with an acute infection are either completely asymptomatic or their symptoms are so mild, they just brush them off. Only about 30% of people will actually present with anything recognizable. And for that 30% who do get sick, the features are notoriously vague. We're talking fatigue, some joint pain, maybe a bit of jaundice from a temporary spike in their liver enzymes. You can see how easily this could be missed. It's exactly why you need that high index of suspicion based on risk factors. So when you do suspect it, picking the right test is everything. To diagnose a current active infection, you need to look for the virus itself. That's the HCV RNA test. The antibody test, on the other hand, just tells you about past exposure. It will stay positive for life, even if the patient cleared the virus themselves years ago. It's the difference between seeing a fire and just seeing the smoke damage afterwards. So let's say we've made the diagnosis. What's the long-term outlook for our patient? What does the natural history of this infection look like? This right here is probably one of the most important takeaways. The vast majority of people who get hepatitis C do not clear it. Somewhere between 55 and 85% will go on to develop chronic disease. Spontaneous clearance is, unfortunately, the exception, not the rule.
Now, that small chance of clearing the virus isn't entirely random. It's influenced by host factors. We know that younger patients, and those who are generally healthier to begin with, have a better shot at being in that minority group that clears the virus on their own. So we end on this question, which is really a call to action for us as clinicians. We know most infections become chronic. We know who's at risk and how to diagnose it. The challenge for all of us is to be proactive, to screen, to diagnose early, and to get these patients linked to the fantastic, highly effective treatments we have today. That's how we can prevent the really serious long-term consequences of this very quiet disease.